Welcome to the section 3 of basic lung physiology. I personally feel that this section is one of the most important section because this is going to help you understand about the ventilator as well. You might be wondering, I'm going to discuss about the mechanics of breathing and all this basic elementary data, but how it's going to help you in the ventilator. But trust me, just watch the video fully and you'll be understanding how we are going to apply a lot of things from this video into the ventilator, which we are going to discuss in the later aspects. Fine. So first, let us discuss the mechanics of breathing. When we want to discuss about the mechanics of breathing, you have to know about the muscles of respiration. That's what I'm going to talk about. Muscles of respiration. You have an inspiration process and an expiration process, and what are the muscles that are going to be helpful for this? First of all, the process of inspiration is an active one, whereas the process of expiration is going to be a passive one. That's it. So how do you do expiration? You just stop breathing. You just stop inspiration. The normal elastic recoil of the lung itself will take your alveoli and the lung back to the original position where you started at the time of inspiration. So just stop inspiration. You're going to start expiration. So this is what is going to happen. So that's why expiration is a passive phenomenon. And how is the diaphragmatic movement? Diaphragmatic movement during inspiration is going to be down. The diaphragm is going to go down, and that's what is going to increase the vertical diameter, and that's what is going to create a negative pressure in the chest because the volume increases and the air is getting sucked in. Expiration is going to be little opposite, which means the diaphragmatic movement will be in the upward direction. It compresses the chest, reduces the volume, pushes the air out. That's what expiration is all about. Which means diaphragmatic movement down is going to increase the vertical diameter of the chest, right? Similarly, diaphragmatic movement up during expiration is going to reduce the vertical diameter of the chest. Clear? Okay. Then how the ribs are going to move? Ribs typically move an upward and outward direction in a normal tidal expiration by a type of movement called a bucket handle movement, which we'll discuss with the help of a diagram in some time. So the ribs are going to move upward and outward, which means the ribs are going to move up and out, which means it's going to increase both. Since it's moving this way, they're going to increase the transverse as well as the AP diameter of the chest. So up and out. So this movement is going to increase the anteroposterior and transverse diameter of the chest, right? Similarly, during expiration is the opposite. That's going to be down and in, which is going to decrease the AP and the transverse diameter of the chest. So it's an exactly opposite process. During normal tidal expiration, the ribs move in a mechanism called a bucket handle mechanism, bucket handle type of movement. Whereas during a forced inspiration, your ribs can have a pump handle type of mechanism, but during normal tidal inspiration, it's a bucket handle type of movement. That's what you have to know. And what are the muscles involved? So we can tell the major muscles and I can tell the minor muscles. Major muscles absolutely is going to be the diaphragm, the first one, the most important one. Diaphragm, it's supplied by the phrenic nerve, root value C3, C4 and C5, very, very important. At the same time, we already told diaphragm is going to increase or decrease the vertical diameter of the chest. Clear? So during inspiration, it's going to increase the vertical diameter of the chest and the volume of the chest. Okay. Similarly, diaphragmatic movement down also will push the abdominal muscles outward. And that movement of the abdominal muscles outward during inspiration is something you can observe in many lean patients. Because diaphragmatic movement down towards the abdomen during inspiration also increases the intra-abdominal pressure. And that is the reason why the abdominal muscles are generally pushed outward. Clear? So then second muscle that is very, very important is external intercostal muscle. External intercostal muscles, which also assists you in normal tidal inspiration, typically supplied by intercostal nerves, which generally originate from the same level in the spinal cord, intercostal nerves. And this is the one that is going to perform the classic bucket handle type of movement, which moves the rib outward and upward. This movement that increases the AP and transverse diameter of the chest. Apart from that, you have a lot of minor muscles or accessory muscles that can work in assisting your breathing, but these accessory muscles are important only during times of respiratory distress or when the patient is having a serious dyspnea because of hypoxemia. So what are the accessory muscles? You have a scalene muscle which elevates the first two ribs, and sternocleidomastoid which is going to elevate the sternum. These are the two most important muscles, and this is the one that's going to form the characteristic pump handle type of movement which we are going to discuss in the next image. Then a lot of other muscles are there like pectoralis major and minor. You have your lat. Like how sternocleidomastoid elevates the sternum and scalene muscles elevate the first two ribs, the lat is going to elevate the lower ribs. One of the important accessory muscles that elevate the lower ribs is your lat. So latissimus dorsi, then to an extent is assisted by erector spinae, trapezius, and levator costarum. So these are some of the accessory muscles that you have to know, but I feel the most important must be the first two, the scalene and the sternocleidomastoid muscle. And what are the major muscles of expiration? You don't have any major muscles of expiration because I told you expiration is a passive process. You don't need any muscles to normally expire. But for forced expiration, definitely you need some muscles which can act especially in times of airway resistance, or if you're voluntarily trying to do a forced expiration. That time your muscles might come into play, like internal intercostal muscles, then your abdominal muscles. The classic abdominal muscles, what are the muscles that are going to help you in expiration? Those are the external oblique, internal oblique, transversus abdominis, and rectus abdominis. Classic abdominal muscles that help you in forced expiration. Clear? So let us see some of the images that are important in understanding these facts which I've told you already. Let us go to it. So you can see in the first image, it's a very simple process and a very elegant process where the ribs are going to move outwards and upwards. That's why the arrow is facing like that. At the same time, the diaphragm is going to move down, overall increasing the volume of the chest cavity. By Boyle's law, pressure is inversely proportional to volume. So if your volume is going to increase in a closed cavity, your pressure is going to definitely decrease. So which means you're going to develop a negative intrathoracic pressure compared to that of the atmosphere. So which will literally suck the air into the chest cavity. And it's the opposite. That's what is going to happen in expiration. You can see the chest wall, the ribs are moving inward and downward. That's why the arrow is facing like that. At the same time, the diaphragm is going to move upward, resulting in shrinking of the chest cavity. It's going to reduce the volume as a result. So which you can clearly see is going to generate a positive pressure compared to the atmosphere inside the chest wall and chest cavity. So which is going to literally push the air out of the chest cavity. So this is how your expiration works. Very simple but elegant process. But let us see some of the anatomical aspects, because it's important to understand why we do thoracosynthesis at the particular location over the ribs. So number one tells you here is the neurovascular bundle. Number two, this is the external intercostal muscle. And number three, you can tell this is the internal intercostal muscle. And these three are the major structures that form the intercostal area. And number four, you can also tell it's the innermost intercostal. And number five, subcostal muscle, the deepest by definition, but it's seen only in the lower ribs. It's not seen in the upper ribs. So by definition, these three are going to contribute to the maximum of the intercostal space and the most important structures of the intercostal space. Clear? And you can clearly see the neurovascular bundle is actually located on the lower portion of a particular rib. So that is why whenever you do a needle thoracocentesis, or when you're going to insert a needle or planning to insert a needle, always do at the upper surface of a particular rib or superior surface of a particular rib. Don't try to enter the lower aspect of a particular rib, because you are having a high chance of damaging the neurovascular bundle when you go through a lower aspect of a rib. So always when you are entering the thorax, enter through the superior surface of a rib. Clear? So this is a very important concept to understand. At the same time, you can also see this particular image where you can see the classic external intercostal action. This external intercostal action is going to create the classic bucket handle movement. You can see the bucket initially when it is in the resting state. You see the handle is not creating that much volume. When you elevate the bucket handle, so what's going to happen is it's going to move upward and outward, creating a lot of volume so that you can hold the bucket and you can even place your hand inside the, the area between the handle and the bucket, right? So this is what we call the characteristic bucket handle movement. You can see the elevation of the ribs, the lateral shaft of the rib. So next one is the pump handle movement, which is typically due to action of two muscles. That is the scalene muscles that elevate the first two ribs. So elevation of the first two ribs is going to be done by the scalene muscles, and elevation of the sternum, which is done by the sternocleidomastoid muscle. So this creates a movement of the sternum that moves like a pump handle. Like the movement of the sternum will be a little bit outward and upward. So it is like this. You see from the side, it's going to be like this. So this is like a pump handle that moves. So the two muscles that are very important are scalene and sternocleidomastoid muscle, and this is extremely important during your forced inspiration process, especially when you are at respiratory distress or when the patient is suffering to breathe, and these muscles are going to come into rescue. At least to an extent they can help. And this image is going to show you some important feature called diaphragmatic excursion. The diaphragm normally moves during inspiration as well as expiration. How much it has moved during inspiration and how much it has moved during expiration, and the difference in movement is what we refer to as diaphragmatic excursion. Let us see the full diaphragmatic excursion. This yellow line here refers the position of the diaphragm at end inspiration. You can tell it full inspiration. And this is the position of the diaphragm. This solid red line is the position of the diaphragm at full expiration. So this is the position at full expiration, and this is the position at full inspiration. And you can see the net movement of the diaphragm. And this is what we refer to as diaphragmatic excursion, because the diaphragm is going to be located at different places in different phases of respiration during inspiration as well as expiration. So this diaphragmatic excursion can be assessed by a simple clinical examination technique called as tidal percussion. And it's still a myth for the students to know that tidal percussion is done for assessing the liver span. No, liver span examination is a different technique, and the tidal percussion you generally do for assessing the diaphragmatic excursion. Clear? So what is the normal diaphragmatic excursion? Normal diaphragmatic excursion during normal tidal respiration is approximately 1 to 2 centimeter only. But if the respiration is forced, during distress, especially when the respiration is having a forced inspiration and forced expiration component, they can move up to 10 centimeter. The diaphragmatic excursion can go up to 10 centimeter in fact. So this is what is very important to understand. At the same time, whenever your ipsilateral diaphragm is paralyzed, let us assume my right diaphragm in mine is paralyzed. So when my right diaphragm is paralyzed, so what's going to happen is, when I start doing my inspiration process, the left diaphragm moves down, it increases the volume, it creates a negative intrathoracic pressure. So it sucks the non-moving diaphragm towards the left side, which means this non-moving diaphragm, that is the right one, goes up and the left one moves down. So that is due to negative pressure created in the chest wall by the moving diaphragm. That is on the left side in my scenario. So left moves down, right is not moving, negative pressure is created, so it gets sucked in. So this is called a paradoxical movement of the diaphragm, which typically happens during an ipsilateral diaphragmatic palsy. Very, very important point for the exam. Clear? So with this, I think we have completed to an extent on the muscles of respiration and some of the important aspects of applied aspects of muscles of respiration. So now let us move on to the chest wall dynamics, which is going to be of tremendous importance. Chest wall dynamics. Clear? So what do you mean by the chest wall dynamics and why this chest wall dynamics is very important? Let us see. First, we have to know one very, very important thing, that there are two types of respiration. In fact, 3-4 different types of respiration. The first one, your physiology textbooks will give only one example of a normal tidal respiration. But the problem is, your physiology textbooks are not going to tell what is going to be the mechanics when the patient is on a mechanical ventilator. So there are some lot of in-betweens are there, like forced inspiration, forced expiration, as well as the patient is on a non-invasive positive pressure ventilation. But let us don't go for the in-betweens right now, and let us only discuss the classic hardcore scenarios where either you do a normal breathing or entirely the machine is doing, that is, you are intubated and a mechanical ventilator is taking care of you. So see two extremes and you will better understand. Remember, normal tidal respiration typically behaves your Boyle's law. And it's completely based on Boyle's law because it's a closed cavity which is communicating with the atmosphere. Your chest wall is a closed cavity and is going to communicate with the atmosphere outside. So typically you can tell your pressure is inversely proportional to your volume, or pressure-volume relationship must be constant because it is calibrated with the atmosphere. But in a ventilator, your lung and chest cavity is not calibrated to the atmosphere. Instead, it is calibrated to the ventilator. It's going to behave like what your ventilator is going to say. It's not communicating with the atmosphere in any way. That's the first point you have to understand. It's a major difference, in fact. So what the ventilator is going to tell. So the ventilatory equations are something different. It's not going to be like Boyle's law. Typically, if you see your ventilatory equation, it says you the peak inspiratory pressure is equal to flow times the resistance plus tidal volume by compliance. This is what we refer to as the standard ventilatory equation, and this will explain your entire ventilator aspects. Clear? And this is also referred to as something called a equation of motion or a standard ventilatory equation, where you can see the volume and pressure as a direct relationship, where if volume increases, pressure also increases, and if pressure increases, volume also will increase. So you can see something, it is very different from your Boyle's equation. Clear? So don't confuse that fact in the first place. When the patient is on a mechanical ventilator, assume the patient is something different here. So now let us go on to a tidal respiration. So during a tidal respiration, let us see what are the changes that you will see in the alveoli. First, let us put the pleural surface. So maybe the pleural surface, I can put something like this. This is the pleural surface. Clear? So now when you have this pleural surface, let us say some of the pressures I'm going to say. This one, let us put P, alveoli, that is the intra-alveolar pressure. Then you have the atmospheric pressure on the outside. Normally the atmosphere, since the alveoli is communicating with the atmosphere here, the atmospheric pressure and the alveolar pressure will be equal to 0 at resting state. Because they are communicating with the atmosphere and they have to calibrate with the atmosphere, they should have calibrated with the atmosphere. Otherwise, the air movement will happen. If there is no air movement at normal tidal end expiration process, definitely the pressure is going to be equal, and that's what we call it as 0. And you can see inside the pleura, you can call it as intrapleural pressure or PIP or PPL also you can call. It's a pleural pressure, intrapleural pressure. And there are two more pressures that you have to know. The pressure between the alveoli and the pressure between the atmosphere is what we refer to as transalveolar pressure or a transrespiratory pressure. Similarly, you can have a difference between the intra-alveolar pressure and the intrapleural pressure, and this pressure is what we refer to as the ever most important transpulmonary pressure, or you can simply call it as TPP, transpulmonary pressure. Clear? Very, very important pressure. If you ask me the single most important pressure in pulmonary medicine, I will tell you this transpulmonary pressure only. Let us see what are all this transpulmonary pressure. Even though the mathematics tells you all these things, the pressure between the two surfaces. For example, transpleural pressure you can mathematically express by intrapleural pressure minus alveolar pressure. And the transalveolar pressure you can mathematically express through alveolar pressure minus atmospheric pressure. So these are the mathematical expressions. Alright, so this is very simple to derive, but what are these? Let us understand. So during a normal tidal expiration, at the end of normal tidal expiration, the lung is said to be at rest. That's a natural lung volume. So which means if you take a cadaver, the lung is not completely collapsed in a cadaver. Clear? So it has to maintain it will maintain its own intrinsic volume, and that volume is what we say something intrinsic to the lung and chest wall together, and that particular intrinsic volume that is present in the lung and chest wall as a whole is what we refer to as FRC, functional residual capacity. Let us kick it on. So you have the alveoli one more time, and you know that this is the pleural space, and I'm going to tell the pleural surface here. And you would have heard most of the times everyone telling during a normal tidal respiration, the pleural pressure is always negative, which means the pleural pressure, intrapleural pressure is always negative. But I don't know how many of you have really understood this particular fact. Let us assume why the pleural pressure is negative. The first reason is this: your alveoli is coated with water, and which means it's going to generate something called a surface tension force. So first reason why your pleural pressure is negative is surface tension. So you might wonder, so what is the relationship between surface tension and here? Let us assume one thing. Your alveoli is present in a box, or your lung is present in a box called as the chest wall. Your lung is adhered to the box called the chest wall, just like this. Clear? Okay. So this chest wall, let us put like this. This chest wall is going to exert a outward force. It's not really an outward force, but let us just assume it's exerting an outward force. Let me give more analogies in some time. And your alveoli is trying to collapse on itself. I told you the first reason why alveoli tries to collapse on itself is the surface tension. And even though you would have studied, there are a lot of surfactant molecules that are secreted by your type 2 pneumocytes to neutralize this surface tension. To be honest, they can neutralize only to some extent, but still some amount of surface tension will still be there, which is trying to collapse the alveoli. Okay, is this surface tension that important and really is going to matter? Answer is definitely yes. Remember, surface tension is not to be underestimated. The surface tension of water is always present on only one zone, that is the air-water interface. Remember, when you go under the water, you don't have surface tension. Clear? If you take this is the water body and this is the air, surface tension is typically present only on the air-water interface at this location only, where these molecules tend to pull each other apart and the surface of the water always tend to behave like a stretched sheet. This is because of the cohesiveness of the molecules on the surface, which is more than what is present on the deeper portions of the water. So this surface tension is an incredible property of water, which makes the leaves, the ants float on the water, the leaves float on the water, and not only the ants and the leaves, even a big ship like Titanic float on the water. And this is the same surface tension during a storm that's going to topple your ship and topple your entire cruise into the sea. So this is not something, like very, easy thing to be underestimated. Clear? Surface tension is something very, very important to understand. It's a massive force. And at the same time, if I tell you one story, for example, when you take your old kings, they used to take barrels of oil along with them. So why they tend to take these barrels of oil along with them? Because oil's surface tension is much, much, much lesser than what is seen on the water. So during times of storm, since there will be so much of waves that will be formed, which can topple their entire ship and the crew, they tend to pour the oil surrounding the ship so that the water, which will contain the oil as a surface, will have less surface tension, so there will be less wave formation. Even though the waves are formed, since they have less surface tension, you can easily break through and it will not topple the ship at all. So this is some very important application. So don't underestimate this surface tension. So it's going to collapse your alveoli because it's trying to always pull each other apart, which means this pulling force each other apart is trying to collapse your alveoli in the first place. So we have seen all these things, fine, this is surface tension. And first of all, why you should keep the alveoli? Do anyone ask this question ever? Why there should be a water over here? With 4.5 billion years of evolution where humans are born, can't you just remove this water and take this water off the alveoli so that you can be happy without any surface tension? But there is the catch. You have your oxygen that is moving in, and this oxygen has to diffuse through this alveoli into the capillaries. This water helps a lot in diffusion. A small amount of water, a great amount of water here will result in alveolar filling and pulmonary edema, where the alveoli will collapse because of that itself. And at the same time, they are going to, create a lot of problems in diffusion of oxygen because there will be too much of water there. But this small amount of water here is very important for increasing the diffusion of the oxygen, because the small amount of water is going to behave like an excellent solvent. So this is something, an excellent to excellent solvent. Like you cannot find a solvent like water in the entire universe. So that is the reason why this water there is very important, a small amount of water. So still that creates a side effect called surface tension, which is acceptable. With small amount of water being there, that is going to create a good thing also by increasing the diffusion of oxygen through its solvent properties. So point number one is surface tension. Second thing, what is trying to collapse the alveoli? So I told you two things will try to collapse the alveoli. One is the surface tension, and second one is the fact that your lungs are elastic, which means the alveoli itself retains its elastic property, which means the alveoli has inherent tendency to collapse on itself. So this is an elastic lung. So it has to collapse. It is going to try to collapse. So these are the two reasons why your alveoli is always in a tendency to collapse. So who's going to prevent this collapse is your chest wall. Who's going to prevent your collapse is the attachment to the chest wall, which means I'm not telling the chest wall will completely prevent. For example, let us assume you have stretched the rubber band or stretched a string and you have tied it to both the ends of a stand. So initially the string force is too much, so it will try to pull the stand a little bit. At one point, the stand will not move any further because it has its own resistance. So it will not pull any further. It will start becoming more and more resistant that I won't come back again anymore. So you can see there will be a point. Initially, the string is like this, very small. You have stretched it and tied it on both ends of the stand. The stand also has come a little bit, and the string also has tried to recoil back. But there will be a point where the stand doesn't come any longer inside. At the same time, the string also cannot recoil any longer. So both will be perfectly balanced at a point. So similarly, the lung that is attached with the chest wall, let us assume the lung is also attached with the chest wall, and the chest wall is trying to expand, and the lung is also trying to collapse like what we saw in the string. So there will be a point where the chest wall, which will resist and will no longer collapse back into the chest cavity, and there is an alveoli which can also no longer recoil elastically. So both the outward force of the chest wall and the inward force of the lung due to elastic recoil and surface tension will balance exactly at a point. That point where they exactly balance is the natural intrinsic volume of the lung and the chest wall together, and that is what we refer to as FRC, functional residual capacity. So what is the relationship between this and the pleural surface? You can see that here. So if you take this is the pleural surface is always a closed cavity. So let us assume it has some pleural fluid also. You can see this is the chest wall and this is the lung, alveolar surface. You can see the chest wall will resist the movement further. I told you at neutral point, the chest wall will not come inside any further, will not collapse any further because it has its rigidity and it's going to resist. The resistance means I'm trying to go outward. So the lung is trying to collapse inward. So these two opposing forces are going to slightly increase the volume of the pleural cavity at resting state. At resting state, the pleural cavity will not be having zero volume, a slightly increased volume. Since it's a closed cavity, by Boyle's law, pressure is inversely proportional to volume. Since the volume is increasing, the pressure should automatically drop. So which means this point, the force of the chest wall is exactly counterbalanced by the collapsing alveoli inside. So now you can see the lung is going to have the pleural space is going to have a little bit excess volume. Because of that, they are going to have a little bit lesser pressure compared to both the areas. Typically, they are going to result in a negative intrapleural pressure. And this is a simple application of the Boyle's law. And you can now understand why the intrapleural pressure is typically negative. Clear? You can understand why the intrapleural pressure is now typically negative. So this is the normal intrapleural pressure and it's always going to be negative, at least during the normal tidal inspiration and expiration. But when you're doing a forced expiration, your intrapleural pressure may become positive sometimes, but during a normal tidal respiration, that is inspiration and expiration, your intrapleural pressure will always be negative only. Let us see the graphs now. After understanding this, we are going to concentrate on the graphs. Zero pressure, that is the atmospheric pressure. So this is going to be the atmospheric pressure. You all know during inspiration, you're going to create a negative pressure within the alveoli. So let us see first the alveolar pressures. And you're going to create a negative alveolar pressure because of the negative intrathoracic pressure and all the movement of the muscles we have seen already. So which means typically the negative pressure that is generated is approximately -1 millimeters of water. So, and this negative pressure that is generated during the inspiration process is going to suck in the air, and this movement of air into the lungs is very important to recalibrate the pressure back to the zero pressure, which means at the end of inspiration, you are going to have this zero pressure only because it's calibrated. And now, slowly during expiration, because of the decline in the chest wall size, which you have seen already because of the recoil of the lung and the diaphragm goes back to its original position, the cavity size will decrease. So the volume will decrease. By Boyle's law, the pressure will increase. So that's why you are reaching a pressure of +1 millimeters of mercury. And now this increased pressure will cause the movement of air out of the lungs and the chest cavity, resulting in recalibration of pressure back to zero. Then this is what happens during end expiration. You can clearly see at the end of inspiration and the end of expiration, the pressure is zero only. During inspiration and during expiration process, only you are having a negative as well as positive pressure respectively. Very important concept. Then typically you can see the pleural pressure again here, -2, -3, -4, -5, -6, you can write up to -30 also, but this is what happens during a normal tidal respiration. That's what we are seeing here. The pleural pressure typically is -4 at the end of tidal expiration, and it's going to become more negative, typically around -6 millimeters of mercury during a normal tidal inspiration. Why it can't become zero like your alveolar pressure? So you can see this alveolar pressure has become zero at end inspiration, but pleural pressure is still a negative -6 at end inspiration. That is because the alveoli is in communication with the atmosphere. So it calibrates. But pleura is not in communication with the atmosphere. Maybe if you create a pneumothorax, then it can communicate with the atmosphere. Apart from that, it is not going to communicate with the atmosphere and it's going to be more negative only. Why it is more negative? Because the stretch of the pleura is more during inspiration. That's why. So now during expiration, the stretch of the pleura decreases because the chest wall size decreases. So it's going to reach your original -4, which is a neutral value. Now, if you put a box like this and if you shade this area, and this is what we call as the famous transpulmonary pressure, that is the TPP, transpulmonary pressure. So the concept of transpulmonary pressure is something you have to visualize by yourself. So it's relatively easy to understand, but let us visualize. You know that the negative pleural pressure is the one that you can indirectly understand that prevents the alveoli from collapsing. And you can understand there is some kind of force that is acting that to prevent the alveoli from collapsing. There are two opposing forces already. One, the chest wall force is trying to move outward and the alveolar pressure is trying to move inward, and both are neutralized at the point, and that volume is what we call FRC. At FRC, again you can understand, at whatever may be the position, you can understand there is some kind of force that is actually preventing the alveoli from collapsing. In a way, it's a negative pleural pressure, but you can give a positive value to that because it's a positive force. In fact, logically speaking, you can give a positive value mathematically, and that positive value, which means that force that holds the alveoli from collapsing, that pressure that holds the alveoli from collapsing, is what we refer to as the transpulmonary pressure. For example, if you think this is the elastic recoil, if this is the lung, and this gravity force you consider as elastic recoil, so I'm holding this remote at this area, which means when I'm holding this remote at this area, the gravity is trying to pull this remote down, but my force that is acting upward in the hand is going to prevent the falling of the remote into the ground. You can remember the gravity is there is elastic recoil, my hand is the transpulmonary pressure. So the transpulmonary pressure on the other hand is the one, this is a positive pressure. You can imagine it's a positive way, it's a positive pressure, but it is something like a negative intrapleural pressure also. I'll tell you how to derive it. So it's a positive force or a positive pressure that is preventing the lung from collapsing back. So if this transpulmonary pressure becomes 0, or if it becomes positive, it goes something different. If it becomes 0 for that, yes, the alveoli will collapse. Or if it becomes negative, alveoli will collapse. Clear? So if transpulmonary pressure becomes positive, so it's going to expand the lungs more. If the transpulmonary pressure becomes negative or it's going to become 0, it's not going to act, it's going to recoil back into its original shape. So the transpulmonary pressure is the one that holds the lung from getting elastic recoil and recoiling back to its minimal volume. So how to derive the transpulmonary pressure? I told you, if you see at end expiration, at this point, it is the pleural pressure minus alveolar pressure minus the pleural pressure. Clear? So alveolar pressure minus pleural pressure, in the sense your alveolar pressure is 0 at this point, minus pleural pressure, which is a -4, is going to be +4 millimeters of mercury. Clear? So here alveolar pressure is 0. Again at end inspiration, I told you at end inspiration always it will be 0 only. 0 and minus of -6, it's going to be +6 millimeters of mercury. And again at end expiration, it's going to be 0 minus of -4, it's going to be +4 millimeters of mercury. So the transpulmonary pressure, you can see, is always positive. You can remember, like, it's the counterpart of the intrapleural pressure. Intrapleural pressure is negative, but we are giving a positive assignment to that pressure, and that's what we called as a transpulmonary pressure. So, and this red shaded area is the thing that you can understand rather than just mugging up the formulas. You can understand the red shaded area is the one that keeps the alveoli from collapsing, which means it pulls the alveoli and keeps the alveoli from collapsing, and that's what we call as the transpulmonary pressure. You can imagine that this red shaded area is the one that drags the alveoli and keeps the alveoli from collapsing. Clear? Suppose if this transpulmonary pressure is going to go over the alveolar pressure, or if the intrapleural pressure is going to go over the alveolar pressure, your transpulmonary pressure is going to become either 0 or negative. Which means this can happen if your intrapleural pressure becomes 0 or positive. So if the intrapleural pressure becomes 0 or positive, the transpulmonary pressure will become 0 or negative. So that is going to result in the collapse of the alveoli, which means there are two ways where you can collapse. So normally the alveolar pressure is here, pleural pressure is here. If the pleural pressure reaches the alveolar pressure or goes above the alveolar pressure, you can result in collapse of the alveoli. Or if the alveolar pressure comes below the pleural pressure, then also you can collapse the alveoli. But neither way it is possible, but the very easiest thing to understand is that the pleural pressure going equal to alveolar pressure or even above the alveolar pressure. Clear? So how can the pleural pressure might become 0 or can become positive or can go above the alveolar pressure? Simple example is in the case of pleural effusion or a pneumothorax. Pleural effusion or a pneumothorax. Let us take a simple example of a pneumothorax. In an open pneumothorax, the pleural pressure is going to be 0, which means now the pleural pressure will communicate with the alveolar pressure. Pleural pressure is going, pleura is going to communicate with the atmosphere. So the pleural pressure will become 0, like equal to that of the atmosphere. It will be no longer negative. So you can see the transpulmonary pressure is equal to the alveolar pressure minus your pleural pressure, which is also is equal to 0. So the transpulmonary pressure is 0, which means the transpulmonary pressure that is holding the alveoli from collapsing becomes 0 now. So the alveoli will collapse to its minimal volume. Clear? When can the transpulmonary pressure become negative or intrapleural pressure is becoming positive? So now you can see this can happen in a tension pneumothorax where the intrapleural pressure will become positive. Maybe let us assume 10 in this example. This is only an arbitrary example. I am not telling the exact value. So like an assumption, let us make it's 10 because in tension pneumothorax, it's not communicating with the atmosphere as well. The air keeps on accumulating in the pleural space, increasing the pleural tension and intrapleural pressure. So here the transpulmonary pressure will be 0 minus 10 is equal to minus 10 millimeters of mercury, which means here your transpulmonary pressure is negative, which is going to collapse the alveoli dramatically. Clear? So in this condition, your intrapleural pressure is actually going higher up compared to that of the alveolar pressure, and that is the reason why you get the alveolar collapse. So this is some examples. Pleural effusion works by similar principle. Fluid accumulation is going to increase the pressure within the pleural space so that that particular area will collapse. So it's very easy thing to understand. It's not a very difficult thing to understand. So this is the importance of the transpulmonary pressure. So I told you, if the transpulmonary pressure becomes negative or the intrapleural pressure becomes positive, you're going to result in alveolar collapse. But what if your pleural pressure becomes more and more negative, or if transpulmonary pressure becomes excessively positive? I told you, negative transpulmonary pressure means collapsing. Similarly, if you have a positive transpulmonary pressure, which means you have a very more and more negative force that is pulling the alveoli up, which means it can be equated to a positive, like pressure called a transpulmonary pressure. So it's going to distend the alveoli more and more. So which means this is the transpulmonary pressure holding the remote air against gravity in this example as I told you. So it's going to push the alveoli more and more up and up, and which means in a lung example, it's going to distend the alveoli more and more. So which means more and more transpulmonary pressure may result in a barotrauma, and that itself may result in a pneumothorax. One of the important examples of a barotrauma is pneumothorax. And the two most important examples of this excessive transpulmonary pressure causing a barotrauma is number one, when you are doing a forced inspiration and expiration, which means you are doing a forced respiration. Why in a forced respiration? That not with 1-2 cycles. Continuously, if you are doing a forced respiration, then you might result in a barotrauma. That is because in a forced respiration, your swings in the pleural pressure and the volume of the chest wall will be too much, which means in a forced inspiration, you are expanding the chest so much, and in forced expiration, you are contracting the chest so much, which means the stretch in the pleura is so much at the full inspiration, and the stretch in the pleura is so less during full expiration, which means the swings in the pleural pressure will be too much. The pleural pressure will be dramatically going down and it will be going on the other side. And this extreme swings in the pleural pressure during forced inspiration, forced expiration may cause extreme swings in the transpulmonary pressure also, resulting in barotrauma. That's the idea. Number two, at the same time, you can also cause this kind of barotrauma, especially when the patient is on a ventilator. especially when the patient is on a ventilator. This is a very important concept to understand. Ventilator is the most relevant, clinically relevant area where you're going to get a barotrauma. Let us put a graph, a small graph. So let us assume this is the atmospheric pressure, that is 0. And you know very well it is a positive pressure ventilation, and most of the ventilators are going to give a constant pressure above the baseline to keep the alveoli inflated, and this is what we refer to as a PEEP, positive end expiratory pressure. At the same time, remember, this is the lowest pressure that your ventilator and the lung system can reach. You cannot go below this pressure because that is how the ventilator works. Even at the expiration, end expiration, this is the minimum pressure that will be maintained. And it also has to be remembered, you should also remember the fact that your respiration, that is inspiration in ventilator, is a passive phenomenon. Even though it's a passive phenomenon, it's a forced one and a positive pressure one. So you're going to give a positive pressure breath. So your pressure is going to actually increase during inspiration, which is the exactly opposite to what will happen in normal tidal inspiration, where your pressure is tending to decrease and coming back to 0. Here, the pressure swings between your PEEP and high pressure. So this is what we refer to as actually the peak inspiratory pressure. We'll not go to that right now. So that's a peak inspiratory pressure. And you can see the pressure is actually a lot higher, and it's completely positive pressure. It's a positive pressure. It depends on a lot of factors which we'll see in the subsequent chapters, but it's going to be a positive pressure ventilation. And the pleural pressure is also going to be very, very different. So it's not going to be the same -4 or -6, depending on what the positive pressure is. Because if you inflate the alveoli with positive pressure, the pleural pressure also will be affected because it's in continuity with the alveolar pressures only. So if alveoli is inflated with positive pressure, your pleural pressure, a lot of chances are that it will become less negative, or it might become a positive one. You can ask me, sir, you told me pleural pressure, if it becomes positive, the alveoli will collapse. No, it's not like that. As long as the pleural pressure remains lower than the alveolar pressure, your alveoli will not collapse. Here, the pleural pressure may become positive, but it may not reach the alveolar pressure. So the pleural pressure will swing in the same direction as that of the alveolar pressure. And you can see now, and this is going to be the transpulmonary pressure. Clear? And this is going to be the transpulmonary pressure here. This red shaded area, which means still you have a positive transpulmonary pressure, which means still there is no alveolar collapse. So this is how your mechanical ventilation works, or a positive pressure ventilation works. But let us see in what cases you will result in a barotrauma. Suppose if the patient is having a very low intrapleural pressure, or a lot of negative intrapleural pressure is there, or if you are going to increase the alveolar pressure, distension pressure of the alveoli. If the alveolar pressure increases dramatically, then you can say either if it comes down pleural pressure, or if your alveolar pressure goes up, you can see that red shade area will increase, which means the transpulmonary pressure will increase, and you are going to result in a barotrauma. So let us see one example where intrapleural pressure, if it decreases, you will result in a barotrauma. So this will happen especially when the patient is having voluntary breathing during mechanical ventilation. This should not happen. Let us put an example. You know very well the lung is attached with the chest wall, and this is the pleural cavity, which is also attached with the chest wall. Clear? So now, let us shade here also. So now, let us assume the ventilator is giving a positive pressure of +20 to the alveoli, and already there was a negative pressure initially in the pleura, but now because the positive pressure is there in the alveoli, let us assume now the pleural pressure has become maybe +15 millimeters of mercury. Clear? So it's a positive +15 millimeters of mercury, because you know that alveolar pressure will be transmitted to the pleural pressure also, intrapleural space also. And already it had a negative pressure. This positive pressure from the alveoli will make it less negative, and sometimes it will be positive also. Now if we see what is the transpulmonary pressure between the pleural space and the alveoli, now you will be seeing it's a 20 minus 15 is equal to 5 millimeters of mercury. So this is the transpulmonary pressure. It's okay. Now let us see what will happen in this example. So the same alveoli, same pleural space, and which is attached with the chest wall. Now the patient is trying to take the breath voluntarily. So now the patient is trying to take breath voluntarily, which means your diaphragm is going to move down and your pleural surface that is attached is also going to stretch down. So now the pleural pressure is actually going to become negative rather than be positive. So if your alveolar pressure remains same during that particular breath, it's 20, and the patient is also giving a breath now. So which means now the pleural pressure may become negative of minus 10 millimeters of mercury. Suppose if the patient is doing a strong inspiratory effort, the pleural pressure may become even more negative. So if you see the transpulmonary pressure now, its alveolar pressure that is plus 20 minus pleural pressure of minus 10 is going to become a plus 30 millimeters of mercury. You can see just because of the voluntary breathing of the patient, whenever the patient is on a positive pressure ventilation, you might result in an exceedingly high transpulmonary pressure resulting in barotrauma. So that's why you have to be very careful when a patient is on a ventilator, especially patients who are at very high risk of barotrauma. You have to always try to avoid these voluntary breaths in the form of neuromuscular blockade. That's also one reason why we strictly do a adequate and a very good neuromuscular blockade when the patient is on a ventilator. Clear? At the same time, how will you measure this transpulmonary pressure in a ventilator? Remember, I told you transpulmonary pressure is equal to alveolar pressure minus intrapleural pressure. It is easy to find out the alveolar pressure because it's the pressure that is given by the ventilator. So the ventilator itself will tell you this alveolar pressure. But how will you measure this intrapleural pressure? Then only you can see the transpulmonary pressure. Then only you can tell whether the patient is going to have a barotrauma or not. It's actually quite easy. So you can see this is the lung. And let us put it is covered with a pleural space. Covered with a pleural space, just for understanding. So as usual, let us put some color to the pleural space. This is a pleural space. And how you are going to measure, find out the pleural space is going to put a balloon into the esophagus. Balloon into the esophagus. And this esophageal balloon is the one that is going to be in direct contact with the pleura, and that is going to tell the intrapleural pressure. So many ICU physicians nowadays put this esophageal balloon. So this esophageal balloon will be in direct contact with the pleural surface, and that is going to give you a intrapleural pressure. So now you have both the data, alveolar pressure as well as intrapleural pressure. Now you can find out the transpulmonary pressure and you can estimate and assess the risk of barotrauma in that particular patient. Very simple. Similarly, if your alveolar pressure increases in relation with the intrapleural pressure, again the curve will go to the other side, and again your transpulmonary pressure will be stretched, which means you are going to result in a barotrauma and pneumothorax. How your alveolar pressure can increase? It's very simple. I told you in a ventilator, pressure is equal to flow times the resistance plus tidal volume by compliance. Suppose let us assume the compliance of the lung is too low. Automatically your your pressure in the alveoli, that is the peak inspiratory pressure, and all the pressures will increase in the alveoli. Very, very simple. So the pressures will increase and the compliance is going to decrease. So if it's a very, very stiff lung, or a very stiff alveoli, which is very difficult to inflate. So the same principle we can apply here also, and it's attached with the chest wall. Extremely same principle. Now you can see this pleural surface is attached with the chest wall, all right. Now if it's a very stiff alveoli, the pressures are going to increase dramatically and this pressure will not be transmitted. Now the pleural pressure will almost remain the same. So intrapleural pressure, let us put only plus 5 millimeters of mercury. Now if your alveoli is non-compliant, or if the lung is non-compliant, the distension pressures and the peak pressures and all the pressures are going to increase dramatically. And because of that, now instead of like here it was plus 20, it's what we put, here it's going to be plus 40 millimeters of mercury. If it's going to be plus 40, now you can see what will be the transpulmonary pressure. Transpulmonary pressure will be alveolar pressure minus intrapleural pressure, which is in turn is equal to 40 minus 5 is equal to 35 millimeters of mercury. Or you can equate all these things to centimeters of water also. That's what the common term we use in a like ventilator based things. But anyway, just for understanding, I'm telling you all these values. So it's plus 35 millimeters of mercury here. Again, the TPP is very high, and again the patient is at risk of barotrauma, which means your compliance also matters a lot to induce a barotrauma. Clear? Apart from a ventilator, there is another patient called COPD patient who is also at very high risk of barotrauma. Why? So, whenever the patient is having a COPD or an airway resistance, remember, because of airway resistance, his incoming oxygen or incoming airflow will be very little. It will be very limited. And this is the pleural space as usual. And this is the chest wall. Clear? So that is attached to the pleural space. Chest wall that is attached to the pleural space. Alright. So now, because he is having this obstruction, his incoming air is going to be very less. So the airway distension pressures will be very less. So in this example, let us assume it's only plus 10. But because his air is not coming in against respiration, against this obstruction, he has to suck, he has to try harder and harder and harder. So he will produce a strong diaphragmatic contraction which stretches the pleural space like anything, but the air is not moving in at all because of obstruction. So now the intrapleural pressure, because of significant workload, significant stretching of the pleural space by increased inspiratory effort, it's going to become maybe a negative of minus 40 millimeters of mercury because of severe action of the muscles of respiration. Now, if you see what is going to be the transpulmonary pressure, it's alveolar pressure that is plus 10 minus of minus 40. So you can see here the transpulmonary pressure is equal to plus 50 millimeters of mercury, which means very, very high transpulmonary pressures you can generate during airway obstruction also because of resistance. This itself is going to result in barotrauma. So very high transpulmonary pressure. So that is the reason why patients with airway resistance and obstructive lung diseases like bronchial asthma, COPD in particular, because they have bulla also coupled on top of that. So COPD patients, asthma patients, cystic fibrosis patients, bronchiectasis patients, all these patients who are having obstructive lung diseases and high airway resistance are going to be at high risk of developing pneumothorax. That is because of excessive intrapleural pressure that these patients have to generate to suck the air against an obstruction. Clear? So this is what is going to happen. Yes. So that is the reason why these patients are going to result in a pneumothorax and a barotrauma. So these are some of the important and interesting applications that you have regarding the transpulmonary pressure. That's why I told you the transpulmonary pressure is the one pressure that you need to completely understand in order to understand the ventilator mechanism, which we will be discussing in the future.